Greetings and a warm welcome to everyone in attendance. I'm Rimpa, your assigned moderator from Clanet, and I extend my cordial greetings to all the delegates from across the country. We sincerely appreciate all the doctors who have taken the time to attend the session with us today. Allow me to briefly introduce our platform Clanet. It is India's most trusted live digital CME platform, which allows doctors to create their own medical content. Now, it is my proud privilege to welcome our keynote speaker for today, Dr. Sumati Saxena, ma'am. Ma'am holds a degree MBBS, MS, is a senior consultant over 30 years of rich clinical experience. She is widely respected for her expertise, patient centered approach, and long standing commitment to delivering high quality medical care at her clinic. And today, ma'am will be talking on the topic fetal growth restrictions clinical approach. Now, without further any delay, I would like to hand over the session to you, ma'am. Please proceed with your talk. Over to you. Thank you.
Okay, thank you. Good evening, dear friends and colleagues. The topic for today's webinar is clinical approach to fetal growth restriction. And by this presentation, we will learn about the how to define fetal growth restriction and how to differentiate it from the small for gestational age fetus. And we will understand the screening and diagnostic strategies, interpret Doppler finding in fetal growth restriction, discuss surveillance and timing of delivery, and review evidence-based management approaches. So, what is the definition? Definition of fetal growth restriction is the failure of fetus to meet its biological growth potential due to a pathological factor. But we cannot define FGR by this definition. For clinical interpretation, it is said that an estimated fetal weight or abdominal circum is below certain threshold such as 10th percentile, then it is a small fetus. It can be fetal growth restricted fetus or it can be small for gestational age fetus. So how to differentiate is by doing the growth chart. By growth chart you can find out that whether it is a small for gestational age fetus in which growth is normal, but in FGR fetus the growth is growth has stopped or slowed down. So you can this and also that we take the help of Doppler in ultrasound, so that if the Doppler studies are normal, it is small for gestational age fetus, and if the Doppler studies are not normal and there is some abnormality in it, then it points toward the fetal growth restriction. You can see in this growth chart, this is a growth chart, and this is the this fetus, black line is going below the 10th percentile and there is a plateau. So this is a IUGR, and this is a small for gestational fetus, though it is low in percentile, but it is following the curve of the growth. So growth is going on, though it is low in the percentile. So it is a small for gestational fetus in which growth is normal. And it is this line indicates the fetus who is IUGR but not growth retarded, as in cases of late FGR. So for differentiating SGA from FGR, the SGA fetus may be constitutionally small but it is healthy fetus, and it show, but in FGR there is a placental dysfunction and Doppler abnormalities which is not there in SGA fetus, and serial growth assessment is essential to differentiate between the two. So in clinical context and maternal disease are also very important. So there are two type of phenotypes in FGR, that is fetal growth restriction. It can be early FGR, it can be late FGR. It means early means below before 32 weeks and late means after 32 weeks. If the FGR is diagnosed before 32 weeks, then it is early FGR. If it is diagnosed after 32 weeks, then it is late FGR. So why we want to differentiate them? Because they differ significantly in many aspects, such as prevalence. Early FGR is less prevalent than late FGR, because early FGR is like 30% and late FGR is more common than in the form of 70%. And prediction by first trimester ultrasound, in which we do uterine artery PI, and it predicts early FGR more than late FGR. And gestational age onset before 34 weeks or after 34 weeks. And placental histopathological findings are more common in early FGR rather than late FGR. And Doppler velocity meter profile is also there, that in early FGR typically umbilical artery, then followed by changes are seen, then middle cerebral artery, then ductal stenosis. But in late FGR, Doppler changes are seen basically in the middle cerebral artery, and CPR is very important, that is cerebroplacental ratio. And associated maternal disease and perinatal outcome. Perinatal outcome is also very bad in early FGR rather than late FGR. So the distinction between late FGR and early FGR is important. So in early FGR, it is seen before the 32 weeks, and when it is said that there is early FGR, if the estimated fetal weight is or abdominal circumference is below the third centile, or in umbilical artery there is absent and diastolic flow wave pattern, then it is a early FGR. Or if it is a abdominal circumference and if estimated fetal weight is less than 10 percentile and associated with Doppler changes, then it is early FGR before 32 weeks. And late FGR when it is after 34 weeks, and if it is below third centile, then the diagnosis is confirmed. And or if there is abdominal circumference and estimated fetal weight is less than 10th centile plus Doppler finding, then it is late FGR. So why there is growth restriction in fetus? There are many pathologies, maybe because of the maternal disease, that is pre-placental factor, then it can be because of the placental factors, then it can be because of the post-placental factor in the form of abnormalities in the umbilical cord, and it may be because of the fetal factors. So in pre-placental factor, if there is hypoxemia, meaning there is decrease of oxygen concentration in mother because of the chronic lung disease or because of the high altitude or because of anemia, then there are more chances of having IUGR, FGR. And if there is a history of smoking, substance abuse, or malabsorption, or poor weight gain, or environmental toxin in the form of air pollution is nowadays a very important factor causing FGR. In placental factor, like maternal vascular malperfusion pathology because of the some secondary to the hypertensive disorder in women like PET, PIH, then there are more chances of having FGR, especially because of the placental factor. And also there can be chronic placental inflammation, that is vellitis of unknown origin, or there can be confined placental mosaicism. In post-placental factors, that is umbilical cord factor, there can be increased coiling of the umbilical cord, there can be increased cord length of the umbilical cord, or there can be true cord knot, or hampering blood circulation, or there can be single umbilical artery, which is a very common cause of FGR, or there can be marginal or filamentous cord insertion. And in fetal factors, there are some genetic disorder in the form of chromosomal, microdeletion, duplication, single site mutation. So they can be responsible for genetic disorders which can lead to FGR. And there are certain structural anomalies like congenital heart disease or gastroschisis which can lead to FGR. And then congenital infections are very important cause of FGR in the form of cytomegalovirus virus infection, toxoplasmosis, herpes, rubella, syphilis, Zika, and malaria. And sometimes teratogen exposure is a cause of fetal growth restriction, and multiple pregnancy is a known cause for fetal growth restriction. So these are the some etiological factors which can cause fetal growth retardation. Now about the risk factor by which you can know that this pregnancy is going to develop fetal growth retardation is history of previous FGR or stillbirth is a strong indicator for development of FGR in this pregnancy, and also history of chronic hypertension, diabetes, and if there is multiple pregnancy and advanced maternal age, low BMI, renal disease and thrombophilia. These are the known risk factors which can cause FGR in the present pregnancy. So this is in the table form. You can see if you take the history, then you can find out the maternal demographics, like if the mother is of advanced maternal age, or if she is underweight, living in high altitude, severe anemia, hemoglobinopathies, environmental factors, air pollution, heavy metals and heat, etc. And in the medical condition in the mother, it is chronic hypertension, chronic kidney disease, SLE, that is systemic lupus erythematosus, inflammatory bowel disease, antiphospholipid syndrome, or pregestational diabetes. These all conditions can lead to FGR in the present pregnancy. Then in the obstetric history, there can be previous pregnancy affected by FGR or preeclampsia. Then you have to be very careful. Then if you do double marker test or biochemical marker test during combined screening, and you find there is low PLGF, that is placental growth factor, or there is low PAPA or high AFB, alpha fetoprotein, these biochemical markers are also indicative of FGR, so that you are alert that this pregnancy can develop FGR. And there are some ultrasound based marker in the form of uterine artery PI more than 95 percentile. Uterine artery notching is not considered nowadays, only PI is considered. And marginal or filamentous cord insertion on ultrasound, two vessels cord, that is in two vessel cord there is single umbilical artery, single umbilical vein. So single umbilical artery is a known cause for FGR. And abnormal placental pathology or decreased fetal growth velocity on ultrasound. These are all the indicators for fetal growth restriction. So key recommendations are all women to undergo risk stratification for FGR at the first antenatal visit to look for high risk factor. And biochemical or ultrasound markers should not be used for universal screening, but if they are available, they can be used. Women at high risk for FGR should undergo close surveillance for FGR from 24 to 28 weeks. So what is the pathophysiology? In pathophysiology, there is a placental insufficiency leading to chronic fetal hypoxia, and which leads to redistribution of fetal circulation in the form that more of the blood is supplied to the brain and leading to brain sparing, and systemic blood oxygenation is reduced, leading to reduced or nutrient and oxygen delivery to in the organs, and which leads to fetal growth restriction, and which is manifested in the form of progressive Doppler deterioration in severe disease. So in ultrasound, you can say there is increased impedance to flow in the umbilical artery in the form of increased PI, and there is arterial redistribution in fetal circulation, meaning by there is a brain sparing effect, more blood is transferred to the brain, and there is when this FGR continues, then there is a failure of compensatory mechanism. Then there is abnormal venous flow, which is interpreted in the form of ductus venosus flow, which gets abnormal, and it is a severe FGR. And there is abnormal fetal heart rate pattern in the last. So when you evaluate the mother who is pregnant, you should take blood pressure and pre-eclampsia assessment in the form of, when you do first trimestral ultrasound, you do the Doppler of uterine artery. And in blood test, do complete blood count, renal, liver function test, torch infection screening when indicated, and consider genetic counseling or testing in early FGR. If the fetus is having early severe FGR, then there is chances of having genetic disorder. So on clinical examination, symphysis fundal height screening is done, whether this is matching with the standard symphysis fundal height. If it is lagging behind 4 weeks, then it is FGR, and you have to confirm it by ultrasound. Then in ultrasound, you have to look for biparietal diameter, head circumference, abdominal circumference, femur length, and you have to calculate the estimate fetal weight, and by which you will come to know about the growth percentile, and the diagnosis of FGR is made. and then you, if there is FGR, then you have to plot the growth chart by doing the ultrasound after 15 days to find out if the baby is gaining weight or not. That is growth velocity assessment. And very important is amniotic fluid evaluation is also done in ultrasound to find out the volume, amniotic fluid volume. And when you do ultrasound, there is a very important role of Doppler ultrasound. By Doppler ultrasound, umbilical artery Doppler is a key surveillance tool. And the changes in the umbilical artery is followed by the middle cerebral artery for brain sparing effect. And then lastly, ductus venosus Doppler in severe early FGR. So abnormal Doppler predicts adverse perinatal outcome. So in umbilical artery Doppler findings, there is increased placental resistance, which is manifested by elevated pulsatility index, and there is, which is followed by absent end diastolic flow, and lastly there is a reverse end diastolic flow. So progressive worsening associated with higher morbidity and mortality. In this diagram you can see this is the umbilical artery Doppler, and this is the in early pregnancy when there is less flow in the diastole because of the trophoblastic invasion is still continuing. But in the normal, it gets normal, then the diastole flow in the diastole becomes much. But after if the fetus develops FGR, there is a decreased flow in the diastole, that is high resistance diastolic fellow. So this is followed by the absent flow in the diastole, and lastly it is followed by the reversal of the flow in the diastole, which is severe IUGR. So how to monitor the fetus when the pregnancy is diagnosed by FGR? Then the purpose of monitoring pregnancy with FGR is to ensure continuation of the pregnancy till it is safe for the fetus to remain in the utero, and plan delivery when the risk of in utero environment exceeds the risk of ex utero environment. So how will you monitor this pregnancy? By the basic is fetal movement count, which is very simple, inexpensive, reasonable tool in home setting, in rural setting. And what happens in it, that there is a reduced fetal movement, which is defined as less than 10 movement in 2 hours during focused maternal counting on rest in left lateral position. And it is well known fact that then fetal hypoxia, when there is fetal hypoxia, fetal activity is reduced. So decreased fetal movement can trigger a hospital visit for further investigation of ultrasound and non-stress test, while normal activity can help to reassure the mother. So, but disadvantage of this matter is lack of objectivity, hence risk of false alarm or false perception of movement despite fetal inactivity. So it is very objective. It is not very objective, it is a subjective test. So we cannot very much rely on this. So then comes the antepartum CTG, that is cardiotocography, and it is also known as non-stress test. Then in it, normal baseline heart is 110 to 160 beats per minute is normal, with periodic acceleration, which what it means acceleration of 15 beats per minute above the baseline, and it is lasting for 15 seconds. If the baby is having acceleration of this category, then it is a reactive CTG and there is no abnormality. But if there is absence of normal variability or presence of deceleration, are non-reassuring. So a reactive CTG is reassuring and has a good negative predictive value of fetal hypoxia, that is 99.8. Fetal hypoxia is ruled out. On the contrast, an abnormal CTG has low specificity for predicting fetal hypoxia. So when there is negative CTG, it means fetus is not active during that test. Then we have to carry on further testing to find out whether the fetus is normal or FGR. Maybe it may be that the fetus is sleeping and test is coming non-reactive, so you can repeat the test after half an hour. Or but if you can do further testing, that is also recommended. The next modality is computerized CTG. It is better than the traditional CTG in predicting fetal hypoxia because it look in short-term variability of fetal heart rate and short-term variability correlates well with fetal hypoxia, increasing the sensitivity of this modality. But we cannot standardize it because it is not available everywhere. So it is not a standard practice. So if it is available, it is well and good. So if the fetus is non-reactive during NST or CTG, then we go for fetal biophysical profile, which is done by ultrasound for 30 minutes, in which we assess the fetal heart rate, fetal movement, breathing movement, tone of the fetal movement, and amniotic fluid level. Since the traditional BPP, in which 30 minutes are taken, it is very long time, so a modified biophysical profile with a CTG and amniotic fluid assessment has been suggested. And if there is abnormal CTG, then 30 minutes BP fetal biophysical profile can be done. Thus, fetal biophysical profile is a more accurate predictor of fetal acid base status at the time of testing and then CTG or NST. So it has better sensitivity and specificity. Therefore, a 5-component biophysical profile can be used to clarify fetal acid base status where a non-reactive CTG or NST is obtained. So how to do fetal surveillance? So then you have to do serial growth scan every 2 to 4 weeks. Growth scan, there is no advantage in doing growth scan weekly because for interpreting the growth on ultrasound, you need at least 2 weeks so that the growth is clear on the ultrasound. And NST and CTG monitoring, biophysical profile, Doppler surveillance protocol, and daily fetal movement awareness. These are the methods for fetal surveillance in FGR pregnancy. So how will you monitor? If the baby is small for gestational age, then but the effective fetal weight is in between the 3rd percentile to 10th percentile, and Doppler studies are normal, Leica volume is normal, then the risk of stillbirth is low. Then growth scan is done every 2 weeks, and Doppler studies can be do 1 to 2 per week, once or twice a week, and biophysical test and NST is done once in a week. Okay, but if the pregnancy is less than 3rd percentile, but Doppler studies is normal and while Leica volume is normal, then even then risk of stillbirth is low, and growth scan is done every 2 weeks, and Doppler study 1 to 2 times per week, and BPP and NST 1 to 2 times per week. But if the fetus is having mild abnormalities like in the form of Doppler, umbilical artery PI is more than 95 percentile, MCA low less than 5th percentile, or cerebral placental ratio less than 5th percentile, or uterine artery PI is more than 95th, plus oligohydramnios and suboptimal interval growth may be problem hai, then you consider inpatient monitoring, especially if other comorbidities. Consider, then you have to give steroid for fetal lung maturation if at the risk of prematurity before 34 weeks, and you do biophysical profile or NST 2 times per week, and Doppler studies are also done 2 times per week, but growth scan is done every 2 weeks. And if there is FGR with umbilical artery absent end-diastolic flow or reverse end-diastolic flow, then inpatient monitoring, steroid, magnesium sulfate injection, and delivery of the fetus. So management principle is to treat underlying maternal condition which is responsible for the fetal growth restriction, if you can treat that. And second is optimize maternal nutrition, which is very important, and rest and hydration. and corticosteroid if preterm delivery is anticipated, magnesium sulfate for neuroprotection before 32 weeks, and individualized timing of delivery. So, if the pregnancy is complicated by fetal growth restriction, we always advise bed rest, though guidelines do not support this. But by bed rest, the reduces the catecholamine release, improves central intravascular volume, and improve uterine perfusion. So, bed rest is important, and low dose aspirin can be given when there is a risk for development of FGR. But if the FGR has already set in, then there is no role of low dose aspirin. Low dose aspirin suppresses production of prostaglandin and thromboxane through its irreversible inactivation of cyclooxygenase enzyme. So, aspirin can be given for prevention. And heparin and low molecular weight heparin is they are anticoagulants and ability to prevent placenta thrombosis and subsequent infarction, but there is no treatment once FGR sets in. So, summary of treatment to optimize perinatal outcome is role of antenatal corticosteroid. It is reasonable to administer when preterm delivery is anticipated, ideally within 1 to 7 days before birth up to 34 weeks. It is very important to know that the improvement by giving corticosteroid, you see the improvement in umbilical artery Doppler, but it is due to result of vasodilatation of fetal placenta's arterial tree and increase fetal cardiac output rather than true decrease in placenta resistance. So, these transient changes should not be interpreted as improvement in fetal status and should not affect management plan. Then, role of magnesium sulfate. It is reasonable to administer it for neuroprotection in women at risk of preterm delivery with FGR up to 32 weeks, and it is seen to decrease the risk of perinatal morbidity and mortality, cerebral palsy, and gross motor dysfunction. So, key recommendations are: there is no medical therapy with proven benefit to treat FGR, but antenatal corticosteroid and magnesium sulfate can be used where indicated to optimize perinatal outcome due to prematurity in the cases of fetal growth restriction. So, now we'll talk about timing and mode of delivery based on ultrasound finding. If the fetus is small for gestational age, there is small fetus. It can be small fetus, or then yeah, and the effective fetal estimated fetal weight is around in between the 3rd and 10th percentile with normal amniotic fluid and Doppler study. Then you can continue pregnancy up to 37 to 39 weeks, and the mode of delivery will be the induction of labor. If there is no indication of cesarean, any other indication of cesarean, and in uncomplicated FGR at less than third centile, like if fluid is normal, Doppler studies are normal, even then you can continue up to 37 to 38 weeks, and the mode of delivery will be by the induction of labor. But when there is FGR with mild abnormalities like early Doppler changes, uterine artery more than 95th centile, MCA less than 5th centile, or CPR less than 5th, or uterine artery PI more than 95th, and associated with oligohydramnios or suboptimal interval growth, then you can prolong pregnancy up to 34 to 37 weeks, and the mode of delivery is most likely cesarean section or induction if there is no maternal condition, with very careful vigilance. In fetal growth restriction with umbilical artery absent and diastolic flow or reverse and diastolic flow, then in absent and diastolic flow you can continue up to 34 weeks in reverse. It depends that if patient is coming with reduced and diastolic flow, then you have to terminate pregnancy immediately with counseling of fetal distress. And mode of delivery is cesarean section. And in cases with abnormal ductus venosus, it's the case of severe FGR, and you have to do delivery with the cesarean section. So there are some absolute indication independent of gestational age. In the maternal condition needing immediate delivery, such as severe preeclampsia, or in cases of abruptio placenta because of the high blood pressure, you have to do delivery. Or in cases of repetitive fetal heart deceleration, sinusoidal tracings, absent fetal heart variability with late deceleration. In all these cases, you have to deliver the fetus. And if the biophysical profile is less than 4 out of 10, or in computerized CTG, STV, that is short term variability, is less than 2.6 ms, then in these cases you have to deliver the baby. And mode of the delivery will depend upon the maternal and the fetal conditions. Vaginal delivery possible in stable fetus. Continuous, if we are going for vaginal delivery, then continuous intrapartum fetal monitoring is recommended in these cases. Cesarean section often required in severe Doppler abnormalities. Multidisciplinary neonatal support is essential for these cases. Now that we'll talk about the complication of FGR. The most common complications are stillbirth or fetal hypoxia, prematurity and NICU admission, neurodevelopment delay, long-term cardiovascular and metabolic disease, and increased all of these lead to increased perinatal morbidity and mortality. So key guidelines and evidence by FICO, SMFM, RCOG, ICOG emphasize Doppler-based surveillance. Umbilical artery Doppler improves perinatal outcome. Early recognition reduces stillbirth risk, and multidisciplinary care improves neonatal outcome. So key recommendation is, whenever you have a case of FGR, confirm the gestational age, because sometimes mistaken dates can be there, and you diagnose that the baby is FGR, but it is not because of the mistaken date. So first is confirmation of gestational age by the correlating it with the first ultrasound. Second, women with suspected FGR should undergo systematic assessment that includes the following: detailed history, detailed examination, detailed sonographic assessment for structure anomalies, soft markers, sonographic signs related to the fetal infection. And Doppler studies are also done that include at least the umbilical artery, and when available also the uterine, middle cerebral arteries. And maternal screening for relevant congenital infection, which should be focused on cytomegalovirus virus, toxoplasmosis, rubella, herpes, syphilis, malaria, and Zika virus in cases of high risk. In low resource setting, the extent of investigation may be limited by available resources. Assessment should include screening for infection such as malaria or Zika virus in endemic areas. Amniocentesis for karyotype as well as microarray and PCR for infectious agents, when available and indicated, should be offered to women with suspected FGR, especially in cases of early onset severe FGR, in presence of sonographic finding associated with genetic or infectious etiology, or polyhydramnios and no obvious sign of placental dysfunction, and when the findings are likely to affect management. So, to take home messages are: differentiate. First important is differentiate constitutional SGA from pathological FGR. Doppler assessment is central to the management. Early identification and surveillance improve outcome. Timing of delivery balances fetal risk versus prematurity, and individualized care is critical. Thank you.
Yeah. So, thank you so much, ma'am, for the wonderful talk. The session was really very informative.
Thank you.
And